Hi, I'm Dr. Marlene Freeman. I'm the editor-in-chief of the Journal of Clinical Psychiatry. I'm also the section editor for the Focus on Women's Mental Health specialty section. I'm also a professor of psychiatry at Harvard Medical School and Mass General Hospital. As a perinatal psychiatrist, I really want to emphasize how important it is for all prescribers who treat women of childbearing potential that pregnancies are often unplanned or mistimed. Many women, even if they're not planning on becoming pregnant, may become pregnant. And many women who we treat across chronic or recurrent disorders may not initially want to have a pregnancy, but then may change their mind over the course of what is, for many people, a long-treated illness. Importantly, about half of pregnancies in this country, in the US alone, are unplanned, which is similar to the global rates. Most women do have children. We want to make sure from the very beginning, when we're selecting treatments for any psychiatric disorder in girls or women, that we're selecting medications that would be reasonable in pregnancy. One, so that we can continue them as maintenance medication if they're needed for severe psychiatric illness. And also, if a woman becomes unexpectedly pregnant on that medication, we want to make sure that it's a reasonable exposure. Now, many of the medications that we use in psychiatry are well studied, and we would consider reasonable in terms of balancing the risks and benefits of an untreated psychiatric disorder and the medication exposure. But there's one major deal breaker, I would say, among the psychotropic medications that are often used, and that's valproic acid or Valproate, or Depakote as a common brand name. It's the worst teratogen known amongst psychotropics, commonly used medications in psychiatry, meaning that it has a high rate of birth defects. And it can be associated with very serious birth defects, like spina bifida or central nervous system birth defects, that often occur before women even know they're pregnant. It's very important that we don't have women of reproductive potential treated with valproic acid. Clinicians often wonder, well, if a patient is using contraception, is it okay if she's on valproic acid or not? And I would say that most prenatal psychiatrists would be in agreement to say the answer to that is no. And that's because contraceptive methods are not 100% effective. And also for bipolar disorder, for which this medication is mostly used, we want patients to have the option to stay on the medication that gets them well. If they're maintained on valproic acid and they become pregnant or they want to have a pregnancy, then they have to stop a medication that's been working and have trials of other medications that may have questionable efficacy for that individual. It has a rate of major malformations or birth defects of more than 10% with first trimester exposure, and the information doesn't get better after the first trimester. It's almost akin to drinking heavy amounts of alcohol throughout pregnancy. That valproic acid is associated with neurodevelopmental toxicity, higher risk of autism, neurodevelopmental delays, and other problems. This has been well documented by our neurologist colleagues who followed children out 3 years, 6 years with neurocognitive batteries and really demonstrated that children exposed to valproic acid in utero do not perform as well as the norm. Articles that we've published in the Journal of Clinical Psychiatry highlight many of these important facts. We've had papers that we've published that demonstrate the high rate of birth defects associated with valproic acid, the neurodevelopmental problems associated with in utero exposure, and the fact that many women who are prescribed valproic acid are not using appropriate contraception. In fact, many patients and their healthcare providers are not aware of the problems associated with valproic acid in pregnancy. We've had papers that have demonstrated this as original data. We've had meta-analyses also on these topics. We've also had editorials. For example, an editorial that I wrote on valproic acid was entitled "Prescribing Guideline for Valproic Acid and Women of Reproductive Potential. Forget It Exists." This editorial really underscores my feelings about valproic acid and what I think are the guidelines for our field. And that's that if a woman is of reproductive age or earlier, so starting with girls, we should not introduce valproic acid from the beginning. Now, fortunately, we have more mood stabilizers than we used to just decades ago. We have many more choices in terms of treatment of bipolar disorder where we would use valproic acid in the first place. I think we just take it off the table. We might consider it for a woman who is postmenopausal or has had a hysterectomy beyond childbearing potential. But otherwise, I think we should just take it off the table. Now, a different perspective and a very creative perspective was suggested recently by Suleiman and colleagues, who wrote an editorial for us called Beyond the Box Warning, a call for regulation of psychiatry's most teratogenic drug. In this commentary, they discussed a proposal for a REMS to assess valproic acid use and to call for regular pregnancy tests and enrollment of patients in a REMS program to mitigate any risk of pregnancy associated with valproic acid. We have that for some drugs that have been FDA approved, for example, Accutane, which is used for acne. We don't have that specifically for pregnancy for any psychotropic drugs now. So I have mixed feelings about that as a perinatal psychiatrist. On one hand, I think it draws important attention to the reproductive teratogenicity of valproic acid and how important it is that we keep that in mind. But on the other hand, I still don't want it used in women of reproductive potential. Even if we had a program to carefully monitor pregnancy tests and pregnancy status, I still think that it shouldn't be used in women of reproductive age or girls who are younger than reproductive age. Again, because it's the most dangerous drug that we have in psychiatry in terms of the risks it poses during pregnancy and the risk for not only infant outcomes and birth defects, but also for lifelong neurodevelopmental problems in children. I appreciate the opportunity to highlight this very important topic here, and please read about it more in the Journal of Clinical Psychiatry. Thank you.